In this case, a deep wrinkle can be observed at the glabellar site due to monolateral mimic hyperactivity of the muscle of the eyebrow. The skin has preserved good elasticity, which allows us to expand the depression towards the external part with a subcutaneous implant. A few minutes after application of the anesthetic gel and an accurate disinfection, the injection of Aquamid can commence. The needle is inserted into the subcutaneous area above the muscular level, and fine lines of Aquamid are laid one over the other in order to augment locally the thickness of the subcutaneous level. We complete the operation by filling the superior part of the wrinkle similarly, using fine lines of Aquamid one over the other. In this case, we continue with the volumetric augmentation of the soft tissue of the zygomatic region. In order to facilitate this implantation and guarantee the symmetry of the implant, we can use the marking of some points of reference, the same as used for the surgical implantation of the zygomatic or malar prosthesis. We also mark the limit of the inferior orbital arch, above which we should avoid any filling. We now have limited the area in which we want to perform an augmentation of the volume. It is a good idea to fix 2 or more basic injection points at each side, which can help in locating the injection site of the needle. Using these injection sites, we can reach the whole area to infiltrate without extracting the needle completely from the skin. We verify the symmetry of all the reference points. They will be very useful if edema immediately after the injection makes it difficult to obtain symmetry of the 2 parts. We proceed with the disinfection of the skin after application of the anesthetic gel. We start the injections using the previously marked injection points, from which we can cover the whole area to fill. Using the retrograde method of injection, we can deposit thin lines of Aquamid in a fan-shaped manner in the subcutaneous layer. The fan-shaped form of thin lines of Aquamid has to be repeated in parallel lines deeper in the tissue, involving the superficial aponeurotic muscular layer, but without letting the needle exit completely, using the same dermal channel. We now proceed with the rest of the marked area, injecting at the second injection point using the same method and without passing the line of the orbital arch. The same retrograde technique with fan-shaped lines from the subcutaneous layer to the superficial layer of the aponeurotic muscle. We verify the position of the implant with a delicate palpation. We proceed with a further augmentation of the medial part of the marked area using the same technique until reaching the desired volume. Palpating the infiltrated area, we can feel how the tissue maintains an optimal elasticity and a homogeneous consistency in order to obtain a natural result. In this case, the Aquamid implant helps to obtain an augmentation of the volume and especially an eversion of the lip in order to correct the vermilion, which is only partly visible and turned inside, trying to maintain the proportion and the projection between the upper lip and the lower lip. When the anesthetic gel has taken effect on the skin, we proceed with an accurate disinfection of the area of treatment. We insert the needle on the border of the vermilion until reaching the subcutaneous layer over the surface of the orbital muscle that is near the needle. The needle must maintain a certain mobility as a confirmation of correct location, not in the muscle, but in the subcutaneous tissue. We start the injection in a retrograde manner by injecting thin parallel lines of gel in a suitable quantity to give the desired effect. It is recommended not to let the needle exit the skin completely. By using the same dermal channel, it makes the injection less painful and reduces the risk of transmitting bacteria. In this case, there is no indication to increase the projection of the lip, so we will avoid implanting in the level behind the muscle. We can see how the filling of the region over the muscle gives a gradual eversion of the vermilion with greater exposure of the vermilion itself. We carry out the same procedure in the lateral part of the upper lip to complete the eversion of the vermilion. The effect of this is also to extend the length of the lips. The same method is used on the left side of the lips. We complete the right side with some thin lines of Aquamid in the lower lip to balance the augmentation of volume in the upper lip. On the left of the chin, we see a depression due to a previous trauma that caused an atrophy of the soft tissues. Now there is an asymmetry of mass and shape between the left and the right side of the chin. We are going to re-establish the volume and shape of the soft tissue in this area by implanting Aquamid. As always, the implant takes place in the subcutaneous layer by transcutaneous injection and progressive expansion of the tissue. This patient wants to modify the profile of the face by creating an augmentation of the chin's projection. We also see that he has the characteristics of the cleft chin, with a deep and very marked cleft that we can reduce with implantation of Aquamid. We continue with the implantation by injecting thin lines of Aquamid, one over the other, near the fold to reduce its depth, and by injecting a greater volume to a deeper level to increase the mass and the projection of the chin itself. In this case, we note the mentolabial folds due to ptosis of the skin and of the superficial aponeurotic tissue. We will perform a correction with an implantation to reduce the depth of the mentolabial folds and to make them less evident. The area that will receive the filling is in an angle delimited by the inferior edge of the vermilion and the fold itself. After application of the anesthetic gel and an accurate disinfection of the skin, the needle is inserted from the side of the lip into the subcutaneous layer. An adequate number of aquamid lines are injected in parallel, using a retrograde technique in a fan-shaped manner, and always at different levels to obtain the desired augmentation of volume. Because the fold is a consequence of the tissue's ptosis, this procedure will not result in a real anatomical correction of the fold. But it represents a simple, fast, and safe method that is able to permanently reduce the evidence of the fold when there is no possibility of a surgical intervention. The patient shows sequelae of a functional septoplastic intervention that has caused almost total ablation of the septum with a prolapse of the tip of the nose and a reduction of the nasolabial angle. There is no support of the distal part of the nasal pyramid with a consequent alteration of the normal airflow in the nose. The patient does not want to have further plastic surgery to reconstruct the nose. Nonetheless, we can improve the present condition both in aesthetic and functional terms with a simple method that enlarges the nasolabial angle, stiffens the columella, and gives a greater projection to the tip of the nose. This will be done with an implant of aquamid at the base of the columella. The implant is injected into the subcutaneous layer under the crus medullaris of the alar cartilage. We observe how the progressive expansion of the tissue due to the injected gel causes a gradual increase in the nose's projection and an increase of the nasolabial angle, improving both the aesthetic appearance and the naso-breathing function by modifying the passage of the airflow in the nose.